Hi, everyone. My name is Vignapamesh, and today I'll be presenting my work with Blaine Rister and Danielle Rubin on COVID-19 lung lesion segmentation using a sparsely supervised mask RCNN on chest X-rays automatically computed from volumetric CTs. So just as of yesterday, the World Health Organization reported more than 167 million worldwide cases of COVID-19 and almost 3.5 million confirmed deaths. Chest X-rays are frequently obtained to determine the extent of lung disease in potential COVID-19 patients and are a valuable source of data for creating artificial intelligence models for both COVID-19 prediction and severity quantification. There are currently a variety of methods for early COVID-19 detection. RT-PCR is a standard diagnostic method that involves the extraction of nucleic acid from viral samples, but it doesn't provide insight into the severity of COVID-19 lung infection. Severity quantification is a task that image analysis is best suited to perform. Most work to date assessing disease severity on chest imaging has focused on segmenting CT images. However, CT scans are performed much less frequently than chest X-rays for COVID-19 patients, meaning that automated lung lesion segmentation and severity quantification on chest X-rays could be clinically valuable. There currently exists a universal shortage of chest X-rays with ground truth COVID-19 lung lesion annotations, and manually contouring lung opacities on chest X-rays is a tedious and labor-intensive task. However, CT imaging is a modality that has been commonly obtained in countries other than the United States, like China, Russia, and India. So CTs with ground truth lung lesion annotations are publicly available. To accelerate diagnosis and severity detection, increase access to treatment for a wider demographic of COVID-19 patients, and augment the amount of open source chest X-ray training data for supervised deep learning models, an automated method of segmenting lesions on chest X-rays of COVID-19 patients that utilizes publicly available CT data is critically needed. Currently, only a few other published methods of segmenting COVID-19 lung lesions on chest X-rays exist. Tang, Sun, and Lee proposed a UNet with a resonant 18 backbone for infection segmentation on chest X-rays. The model detected lung lesions fairly accurately, but high-density anatomical structures like bronchial trees were often perceived as additional opacity regions and compromised model predictions, indicating that the network leaves room for improvement. Oh, Park, and Ye proposed a patch-based CNN inspired by statistical analysis of potential imaging biomarkers of chest X-ray radiographs. However, their model only segments the lungs and heart on chest X-rays and does not provide any information on opacity regions besides saliency maps, which don't contain accurate lesion outlines and, as such, are difficult to use in clinical settings. To address these issues, we developed an automated pipeline for COVID-19 lung lesion segmentation on chest X-rays. Due to the lack of publicly available annotated chest X-ray data, we implemented a reprojection algorithm to generate coronal X-ray projections from annotated volumetric CTs to augment small X-ray training datasets. We then trained a mask RCNN model on this mixed dataset, which achieves superior accuracy to past methods with only limited supervised training. Here is a short summary of the data we used as part of our research. We collected 241 annotated axial CT volumes from various public sources with which we generated coronal X-ray projections. We also used 100 chest X-rays with COVID-19 lung lesion annotations provided by General Blockchain Inc. So our research can be divided into two components: CT to X-ray conversion and lung lesion segmentation. Generating projections from volumes data is a fairly well-known task. We implemented a pixel-based reprojection method modeled as a subproblem of ray tracing as proposed by Mark Lavoie in 1990 to compute chest X-rays as coronal projections of axial CT volumes. Essentially, the x-axes of CTs and chest X-rays match up, while the z-axis of a CT volume, which is front to back along the patient, corresponds to the y-axis of the X-ray. As shown in the equation at the bottom of the slide, we loop through the CT slices from front to back, and for each z position, we take a column-wise sum of the pixel values at each x position, and assign that sum to location x, z in the coronal projection. The image at the top is a sample annotated X-ray generated from CT and mask volumes. Besides being used to compute coronal X-ray projections, the CT to X-ray conversion algorithm is also used to generate the labels for each sample in the training dataset. Given a volume of ground truth mask slices in grayscale format, the CT to X-ray conversion algorithm is used to generate a coronal mask projection from the axial mask volume. A recursive flood fill is then performed on the mask projection to generate sets of pixel values, where each set stores the coordinates of the pixel values within a single disjoint opacity region on the projection. Each set is then used to generate a concave hull, as shown in the bottom figure. These concave hulls are passed to the mask RCNN as labels for the X-ray projections in the training dataset. We employ a naive implementation of the mask RCNN framework for the task of instance segmentation. As shown in the diagram, training samples are first fed into a ResNet 101 backbone network, convolved, and passed back to the region proposal network to generate a set of proposed regions possibly containing lung lesions. Anchors corresponding with each region of interest are then passed through a series of feature maps to generate masks outlining COVID-19 lung lesions on the input chest X-ray. The final output is a predicted mask, which can then be overlaid on the input image for clinical use. Due to the scarcity of publicly available chest X-ray data with COVID-19 lung lesion annotations, we use data augmentation to improve model accuracy and reduce potential overfitting. So we implemented the 9 techniques shown in this diagram. We then trained identical mask RCNN architectures on 2 different training datasets of the same size for exactly 30 epochs with the same test dataset, allowing us to compare results across training datasets. The first training dataset consisted of 60 chest X-rays with ground truth annotations. The second consisted of 10 randomly chosen X-rays from those 60 in dataset 1, as well as 50 X-ray projections from CT volumes. Our model was then evaluated on the remaining 40 chest X-rays from General Blockchain Inc. Okay, so here are the results of our model. When trained on dataset 1, the proposed model achieved an IOU score of 0.81 plus or minus a 0.03 margin of error. When trained on dataset 2, it achieved an IOU of 0.79 with the same 0.03 margin of error. So the similarity between these results indicates that we can replace up to 83% of chest X-ray training images with X-ray projections generated from CTs while maintaining model accuracy. These figures contain some representative results. On the left, we see ground truth and predicted masks for a sample of 5 chest X-rays from the test dataset, where the top row represents the ground truth annotations, the middle row contains the predictions after training on dataset 1, and the bottom row contains the predictions after training on dataset 2. Chest X-rays are the same within individual columns. And the figure on the right is of the same format, but a different sample of 5 X-rays is shown, and the segmentations are overlaid on the images. Our results far exceed the few existing published baselines. Tang, Sun, and Lee's UNet segmentation model is the only published COVID-19 lung lesion segmentation framework with publicly available model schematics. When we implemented their architecture and trained it on datasets 1 and 2, their model achieved IOU scores of 0.38 and 0.49, both of which are significantly lower than our model's corresponding IOU scores. And since we trained our tested our model and the baseline model on the same datasets, our mask RCNN likely outperformed the UNet baseline due to its structure as a series of recurring feature maps rather than contracting and expansive paths, the presence of the RPN, the region proposal network, and its greater complexity in the form of a ResNet 101 backbone rather than a ResNet 18 backbone. Moreover, when the predicted masks are on the input images, our results can be utilized in clinical contexts to quantify the amount of lung disease on chest X-rays of COVID-19 patients, and can thus assist in prognosis detection and treatment determination. A limitation of our study is that we use small amounts of publicly available data. However, our results still suggest that improved accuracy can be obtained by augmenting chest X-ray data with large numbers of frontal projections of public CT volumes. Training and testing our model on larger datasets could improve future results. Here are a few key references for our paper. And finally, these last three QR codes can be used to access our GitHub repository with our code and documentation, our preprint paper on RZIV, and our contact information. Thank you for your attention.
All right, thank you so much, Vignav. We do have a question here from Graham King. Are you aware of the UK National COVID Chest Imaging Database as a potential source of more data? And then they also provided a link.
Oh, yeah, I'm not currently aware of that, but that's definitely something I can look into for our future work. Yeah, that's definitely great.
All right, anybody else with any questions, feel free to type them in. In the meantime, I think your data here is really interesting, very fascinating. Just a quick question that I had, a couple of them, I guess. Do you know if all of the x-rays were acquired or I guess made through those projections in the same technique, like antero to posterior versus postero anterior, or if that makes a difference?
Yeah, so what we found is when we implemented our own reprojection method, switching between those techniques didn't actually make a difference in the quality of the coronal projection, and both of them had pretty much the same results on the final accuracy of the masked RCNN model.
Excellent. Dr. Tessa Cook added that MIDRIC would also be a great source of data for your future studies. The other question that I have is the fact that people got CTs seems like it would be a selection bias in and of itself. They were probably more clinically sick or had a more severe presentation to start with. Did you tend to see that alignment when you were doing the analysis during round 2, where the x-rays that were made from CTs tend to represent more advanced disease?
Yeah, that's actually a great question, something we could definitely look more into. Right now, we didn't actually focus on that problem that much because the idea is to just use these extra sources of CTs as sort of a form of data augmentation for the actual X-ray models. And we found that regardless of the actual amount of sort of consolidation on the CTs and whether that showed any sort of selection bias, still more annotations on the CTs would help the accuracy of the model in detecting those same kinds of annotations or similar annotations on actual X-rays in the test data set. But that's definitely something we could look into further. It's a great suggestion.
Excellent. All right. And Dr. Kurt Langlotz has added a link to MIDRIC data in the Q&A. So it seems like there are a lot of people who are enthusiastic about your research and ready to help you get some more answers with some more data. So thank you so much.